Going to get started. Today we're going to start our meeting off with our guest speaker, Dr. Braden, and she is here to speak to us about creating the Braden Scale. So here we are.
So I'm here today to talk to you about the Braden Scale. I know that you got this in the email. Did you ever cover it in class? Okay. When I put this together this weekend, I thought about it and I thought, gee whiz, it has been 30 years since I first published the research on the Braden Scale, but it's been even longer since I actually developed it. So this one, okay. Okay, what was the impetus for developing it? In the early 80s, the Robert Wood Johnson Foundation was offering a grant to schools of nursing. They wanted schools of nursing to partner with nursing homes and develop a partnership much like the VAs partnered with medical schools years ago. And prior to that time, though I know that the VAs had a little rough period in recent years, but prior to the time that they became associated with medical schools, their primary claim to fame was poor care. Then they became associated with medical schools. All of their physicians were like chiefs of departments in a medical school. They had a full range of medical residents, medical students, etc., all of whom helped to bring up the quality of care. Robert Wood Johnson Foundation hoped that putting schools of nursing into partnership with nursing homes would accomplish the same things. First of all, because the primary thing that goes on in a nursing home is nursing care. And secondly, because the presence of students and faculty always challenges staff to think about things, always has you looking through a different, perhaps evidence-based and research-based view of the world. So I wrote the grant, and it was funded, and so I began. And one of the primary objectives of the Teaching Nursing Home Project was to bring nursing research to bear on clinical problems. So I did a survey of the staff. I did a survey of the staff, and we eventually narrowed it down to about 11 problems. So then I put out requests for proposals to the nursing faculty at Creighton and the nursing faculty at UNMC, where we had a subcontract for a nursing home in Lincoln, which is Madonna. I think maybe most of you have perhaps heard of Madonna in Lincoln, okay? Here in Omaha, it was Mercy Care Center, which since developed a terrible problem with black mold and had to be taken down. So Mercy Care Center is no longer around. At any rate, I got back a number of proposals. I took them to a research review committee. We took the 6 best ones, and then we went to the directors of nursing, and they said, well, gee, there's nothing in here about pressure ulcers. And I said, well, there's nobody studying it. They said, but that's our biggest problem. I said, well, there's nobody studying it. You know, I mean, people who have, at the time I was a master's prepared clinician, I said, people who have their PhD, they often find their research topic during their doctoral program, and then they continue to pursue that. And there's nobody studying pressure ulcers. And they said, well, Barb, you're the project director, then you'll have to do it. So that's how I got started, by coincidence, really. And maybe a little bit of forceful encouragement by the directors of nursing. So I started out with a chart review. Could you hand me my fluid? Okay. I started out doing a chart review, and of course, when you put strange people into nursing homes, they're pretty suspicious of you. So when they saw me looking at charts, the staff would sidle up and say, what are you doing? And I said, well, I'm taking a look at patients who have pressure ulcers to see if I can decide what's happening, because I had put a nurse practitioner in charge of quality, and to orient her, I put her on all 3 shifts, working with the nurse aides, not working with the nurses, working with the nurse aides, so she could see what the bedside care was about. And she told me that turning schedules were just their magnificent obsession. And so I was pretty sure that wasn't it. And yet they said it was their biggest problem. And indeed, they had patients with big, huge pressure ulcers. And so they said, I said, I know that it's not your turning schedules, so I'm looking to see what it is. They said, well, who you got? And I tell them it's nutrition. Okay, so I'd look, and sure enough, it would be a patient who was terribly nourished. So I happen to have funded a study from a woman at UNMC who was studying nutrition. Madonna had a 5-meal plan, and Mercy Care Center had a 3-meal plan. Madonna, because they thought that small, frequent meals would be better for the elderly, and Mercy Care Center, because that's the way the dietary staff had operated for Bergen, which it was attached to. And so, at any rate, she wanted to see which was called the Gosnell tool, because it had a nutrition subscale. So after we did that study, it turned out nobody got a pressure ulcer, so we couldn't tell much of anything. One of the admission criteria was the patients had to be able to feed themselves, and as it turns out, there's a strong correlation between being able to feed yourself and being able to move and walk in other, or at least move in other ways. So, but we did find out that the Gosnell scale, that when it was a 3-point good for a 4, and that everybody, most of the time, they dumped people into fair. You know, very few people ended up in poor, very few people ended up in good. So I talked to my research partner, and we decided we were going to write an NIH grant to investigate nutrition as a cause of pressure ulcers. Now, there's been a lot of research done about how you cannot heal a pressure ulcer unless you have adequate nutrition. But there hadn't been any to say, does poor nutrition lead to higher risk for developing pressure ulcers? So we went about doing that, reviewed the literature, we're writing it up, and then Dr. Bergstrom said to me, you know, we can't take a chance that nobody will develop a pressure ulcer, so we should be only admitting people who are at risk, and then see, does nutrition push them over the edge into high risk? So she said, what about those risk assessment tools that I'd use for a chart review and for that mini study? And Nancy, who was an eternal optimist, said, well, go home and fix the thing. So by that time, I'd been immersed in the literature for a long time. I'd seen the previous 2 scales. One was Norton, done in England. The other one was Gosnell, done here in the US. And I knew what the problems with both of them were because I'd struggled with using them. And so I sat down and I did what I thought was a fix. For example, one of them, I think both of them, had a subscale called mental status. And, you know, mental status, when I get these back from the nurses, they would have 2 things circled under mental status, confused and alert. So I thought, you know, there's something wrong with this concept. One, you're talking about level of consciousness, if you're talking about alert, you know, and confused, then you're talking about mental status. Okay. So I decided, I thought about all my patients, and I thought, well, a lot of them who are very confused are speeding around the nursing home. You know, you have more trouble keeping them inside the nursing home than having them be in bed, until the late stages of Alzheimer's or dementia, where they can no longer, even if they're in pain from laying on one side for a long time, even if they're in pain, the frontal cortex is so damaged that pain impulses rising from the spinal cord to the frontal cortex aren't recognized as pain. And so you will turn them, or nurses turn them, and they find their way immediately back to kind of a fetal position on the same side that it has to be hurting because they're developing a pressure ulcer there. So I ended up changing that to sensory perception. You've got to be able to perceive the pain to do something meaningful to relieve it. I mean, all of us feel pain eventually, even in these cushy little chairs, but we move. We cross our legs one way, cross our legs another. There's something telling us all the time to move. Okay, so it was really, and it went on throughout each of the subscales, doing that kind of concept analysis, really based on my clinical experience. So I developed the scale, mind you. Then, after that, we did the research, and then I went into my doctoral program. And one of the first things that they said was you have to develop a conceptual framework. So, of course, this is something that should come first, but it didn't. So I had to think back on now what led me through this, my thinking on developing the Braden scale, and what is the right relationship between concepts. So pressure sore, pressure ulcer development, now they decided to call it pressure injury, is really an interaction between the intensity and duration of pressure that a person's bony prominence is exposed to, and the ability of the tissues over that bony prominence to tolerate that kind of pressure. So if you're like me, you've got plenty of padding, you tolerate a little bit more pressure than a 98-year-old bony little woman, okay? Your tissues are in better shape. The same thing you'll see in spinal cord injuries. Very, very rare for a 16-year-old, well-muscled young man who's got a spinal cord injury to develop a pressure ulcer during rehab. They usually develop it 2 to 5 years later when there's muscle atrophy and they've got a job and they're sitting all the time in one position, etc. The ability of the tissue to tolerate that pressure is important. Now, there are certain things that lead people to be exposed to intense and prolonged pressure. Deficits in mobility, deficits in activity, and deficits in sensory perception. For tissue tolerance, you've got some things that occur on the outside, that extrinsic factors that cause them to be more at risk. So moisture, especially if the exposure to of the skin to moisture is constant, it becomes macerated, and then very easily it will just slide off sometimes. But the tissue becomes very friable and can be easily injured. Friction and shear. Friction will actually decrease the amount of pressure that it requires to cause a pressure ulcer. So if you have a constant rubbing against the sheet, so that some patients will be quite agitated, or they slide down in bed all the time, and that exposure of the skin to friction is very harmful. Shear is just, they're both tangential pressure, okay? But shear is harder, so that they're up in the bed, and then they begin to slide down, but their skin sticks to the sheets. And so you get that shearing, and it's just like the blood vessels that come from the muscle, go out through the fascia, become actually kinked, okay? So it's just like taking a garden hose and kinking it. It shuts off the blood supply, so that you will see, and you'll even see a typical shear injury will be triangular in shape and can be quite deep because the blood supply has been shut off from the fascia up. Okay, intrinsic factors, things internally that can make the tissues less tolerant of pressure. We thought, at least, poor nutrition would be one. Lots of different reasons. Vitamins A and C are really essential to skin health. Zinc, protein will replace collagen, or will help you to build healthy collagen and elastin, and those are kind of the bed springs of the skin. So nutrition, we thought. Aging, we know that collagen and elastin deteriorate as you age, thus giving you wrinkles. I was so shocked when I got glasses and found out I had them. Low arteriolar pressure, low diastolic pressure in particular. And this is just like if you've got a garden hose and you turn it onto a trickle, you kink it off and you'll get complete occlusion. If you've got a garden hose where it's coming out like a fire hose, you're going to have a hard time kinking it off. So the fact is that actually the one good thing if old people should have a little bit of hypertension is that they're actually be less prone to pressure ulcers. If it's low, they'll be more prone. And low oxygen tension if their PO2 is very low. This is particularly important in critical care situations. Okay. So the Braden scale has 6 subscales. 5 are rated from 1 to 4. The last one, friction and shear, is rated from 1 to 3. I just couldn't think of any way to describe it adequately to pull out both ends, so I got a 4 point. So that's why it's 1 to 3 instead of 1 to 4. Total scores range from 6 to 23. The lower the score, the higher the risk. And people said, why did you do that? Because it's so counterintuitive. But I did it because we were working in places where rehab was going on, where you had physical therapists and occupational therapists who depend on functional assessments. And the lower the function, the higher the risk. So I wanted everything related to function to go in the same direction. Okay, this is the sensory perception subscale. You'll notice that it's got 2 levels to it. The top one deals with level of consciousness, okay? The lower one deals with cutaneous sensation. Okay, so you can have somebody, let's say a person who has a spinal cord injury, who is perfectly alert, no problems with level of consciousness, but they have a problem with sensory perception, right? You can have people who, let's say they go as low as a 2 in level of consciousness, but they're still responding to painful stimuli by moaning, thrashing, something like that. Okay. I'll leave that there until we get through all the scales. Activity subscale is really, we're talking here about the degree of physical activity. So ambulation is an important part of that. Walks frequently, walks occasionally. Ability to walk is severely limited or non-existent, etc., and confined to bed. Now, one of the things that the other risk assessment tools had was how much help does a person need? The problem really isn't how much help do they need, it's how much help do they get. And Madonna had 3 times the nursing staff on every level that Mercy Care Center had. And they had about 1/3 of the problem with pressure ulcers that Mercy Care Center had because they got the patients up and walking all the time. They had sufficient staff to do it. So I base this on how much can the patient actually do. In nursing, there's one nursing theorist that probably most nurses adhere to, and she says if the patient has a self-care deficit, then your interventions are to help make up for that deficit. So we're not talking here about what the nurses do, just what can the patient do? And then the interventions should come later. Mobility is ability to make changes in body position. You and I make frequent changes, even in our sleep. Slightly limited. If there are even slight movements, they found that this will decrease the incidence of pressure ulcers. So they don't have to be able to flip themselves over. They can just be able to move a little bit, bend, even just moving their arms will change the SpO2 at the sacrum. Okay, very limited. They just make occasional slight changes in their body or extremity position, but they can't make any major ones. And then completely immobile. When you combine this with level of activity, let's say that you've got somebody who is bedfast, they might still be able to get a 4 on mobility, okay? Because even though they're confined to bed, they may be able to turn themselves quite easily. However, if they're confined to bed and you begin to go down this scale, your risk goes up exponentially. Moisture. The other scales had incontinence as a risk factor, and it's true that being incontinent puts them at risk. But I've had patients who maybe flooded the bed once a shift, and you went in and you changed them, and they were dry. You washed them off, they were dry again, and they weren't nearly as much at risk as the patient who dribbled urine constantly so that they were always wet. The same with diarrhea, or the same with bowel incontinence. If they just have one bowel movement a day or once every other day, or a stimulated bowel movement, as you'll see with spinal cord injured patients, you know, and they're cleaned up right away, they're not at risk. But if they have oozing diarrhea that's constant, and you know, you do what you can, but it's hard to keep it away from the skin, they're at much higher risk. So the moisture is the degree to which the skin is exposed to moisture. Okay. Nutrition. By the way, we did this big nutrition study. I didn't bring any of the slides from that, but we measured vitamin A, vitamin C, zinc, total protein, total iron binding capacity, hemoglobin, hematocrit, human, total proteins, etc. So we measured all this stuff, and we had research nurses that watched everything that the patients ate. We had the formulary from the nursing homes that said what was in each recipe and what their portion size was that they sent out in the trays. And we looked at all of that, and here's what we found. Nothing made a difference except current dietary intake of protein. They could come in severely compromised in their nutrition, but if you could refeed them, and if their protein intake and protein levels went up, because we followed them for 12 weeks, and if you could see that go up, they were not at risk, okay? But actually having a low protein on admission was not in itself a predictor of who would not develop a pressure ulcer, just what they ate once they got there. And then, whoops. I don't want nutrition. Yeah.
Sorry.
Okay. Then we looked at the literature to look at TPN and tube feedings and that sort of thing. And mostly what the literature was saying on all of this is that you can replace it up to a point, you can bring them close to normal, but they never reach a totally normal nutritional profile if they're on either tube feedings or TPN. The micronutrients may be missing. There may be something about the diurnal variation when people take meals. Don't know what all it is, but in the nutritional literature, it said none of them come up to really excellent quality. So you can see that if they could not take in food orally, that we also had something scaled for tube feedings and TPN. There, you'll see that 2 is probably inadequate, receives less than the optimal amount of liquid diet or tube feeding. When we were doing this study, I found 2 patients with big pressure ulcers that were getting 700 calories a day by tube feeding. I said, what are you doing? They said, well, if we go any higher, they get diarrhea. I'm like, well, get a different formula then, you know? There are ways to alter this. Call in the dietitians. And so we cured that nutritional problem in those patients. Friction and shear. This looks at, this is where I do talk about assistance being needed, because often with assistance being needed, people are not careful in pulling patients up in bed. And so you'll have the skin moving along the sheets. Okay, and then you also have the patients who tend to slide down in the chair or in the bed and become exposed to shear injuries. So there's friction and shear. Okay, these are, then when we did this study, we could see by their admission Braden scale and by the Braden scale score immediately before the observation when we found a pressure ulcer. Okay. So we took a look at those in many settings. I did one big study over here at what's now CUMC, at that time St. Joe's, did one at the VA, one at UNMC, Mercy Care Center, Madonna. And we looked at all of these and found that about 15 to 18 is mild risk. Some patients will get pressure ulcers. Those who do, it's almost always stage 1, maybe an occasional stage 2 from friction, but mostly stage 1. Moderate risk, 13 to 14, you'll have, again, stage 1s, more stage 2s though in this level. 10 to 12, they're at high risk. They had mostly stage 2s, some where you were kind of concerned it might convert to a stage 3. And I think in one setting we did have 2 or 3 stage 3s fell into that category. 9 or below, all of our full thickness pressure ulcers occurred in people who had this low of a score. Okay. So there's some gradations, and of course there are different things. There's a difference to the intensity of intervention that you do at each of these levels. So mostly when you use the Braden scale, you're looking at this risk assessment as clinical data. Okay. So each subscale score gives you your initial appraisal of a patient's specific problems and their functional deficits. Okay. Now, it may be, in particular for PTs and OTs, functional therapists to do a more definitive functional assessment if they find functional deficits. It can be a flag for assessments that need to be explored further, calling the dietitian, calling the PT, calling the OT. And it's a guide to the types of interventions. And I'm going to go through those subscales again and ask you what it is that OTs would do. I know what nurses would do in certain situations, but I'm not as familiar with the practice of occupational therapy. So you have to give me some examples. Then after you've done that type of assessment and determined some interventions based on that, after that you look at those total scores in those risk categories. And so the higher the level of risk, the more intense and more frequent perhaps your interventions will be. Okay, more high tech, you know, for nurses it would be maybe just getting them up and walking more often. For those who are mildly impaired, to having a bed that does a lot of the moving for them, you know, very high tech bed. Okay, so let's, I don't know, yeah. Before we will go back, but let me talk about clinical judgment. This is a little schemata that you use for determining the sensitivity and specificity of a diagnostic test, a screening tool, etc. If you're talking about a diagnostic test, if the test is positive and they developed the disease, that's a true positive. And for a diagnostic test, you'd like anytime the test is positive to have almost everybody have the disease that you're testing for, right? True positive. If the test is negative, but they develop a pressure ulcer, that's a false negative. Okay. If their test is positive and they don't develop a pressure ulcer or whatever it is you're testing for, That's a false positive. If the test is negative and they don't develop the disease or the pressure ulcer, that's a true negative. So for diagnostic tests, you want like everybody to be in the true positive and true negative group, or at least 99%. When you get into screening tools, you've got a little more leeway. And when you get into tools like the Braden Scale or like a cardiovascular risk assessment that's just a list of problems, those you're looking for a disease that's not yet present, and you're predicting as long as has actually pretty fair sensitivity and specificity, as good as mammography, for example, which is much higher tech test, and believe me, much more painful. But the Braden scale is enhanced by the use of clinical judgment. In other words, you know, you're taking a look at the whole patient, the whole picture. You're seeing different things, and you can decide on your own: is this a false positive or false negative? Okay, so here's a case where two cases. In each case, the Braden scale score is 12, which would put them in the high risk category. Right? One is a 24-year-old male, appears healthy and well nourished, has just had a hernia repair. He's in the immediate post-op phase, not even recovered from anesthesia yet. That's why his score is a 12. Here's a 60-year-old male, 500 pounds, hypoventilation syndrome, so he's got low PO2, some congestive heart failure, he's got edema, low blood pressure, and somnolent. Okay, so which one is really at high risk? Right. So that's your true positive. That's the one you're going to intervene with. That's a false positive, right? It's 12, but it's a false positive because you know in a few hours he's going to be up and around. Okay, these are cases of either a true negative or a false negative. Here you've got a 70-year-old male, appears healthy but overweight, diabetic with arterial insufficiency, peripheral neuropathy, and a history of diabetic ulcers. Admitted for a laparoscopic cholecystectomy. The other one is a 30-year-old male, marathon runner, healthy but very thin, admitted for arthroscopy. Okay. Which one is the true negative? 30-year-old. Very good. It's not hard, you know, but you do have to apply judgment because they both scale scores of 21. Okay. So what you want is you want to have risk assessment being performed. You want to have somebody with good clinical judgment, considering individual factors and using that judgment. When you get that, you have not only better prediction, but also more efficient prevention, okay? Because you know which ones you must intervene on and which ones you don't need to. Yes? Oh, in 5 minutes. I'm so sorry. Okay. Well, we won't have time to talk about what OTs do. This is what happened the first in '92 when this was implemented in the LDS hospital in Salt Lake City. And this was in intensive care. The 1, 2, 3, 4 across the bottom is severity of illness. So you have those in 4 were in danger of death. They didn't know if they'd make it through the day. You know, those in 3 were very, very ill, but you thought they were going to make it. Those in 2, you were pretty sure unless something went terribly wrong, they'd make it, but they were really sick. And those in 1 probably needed to be discharged to the floor very soon. Okay. So then they looked at, the red line is the percent of those patients that fell into those categories that developed a pressure ulcer during their stay in ICU. Then they implemented the Braden scale, Did not even talk to the nurses about what type of interventions, just said this is an assessment we want you to do on all patients and act according to your judgment on what you should do. And you can see that even among those who were most severely ill, that it resulted in a massive drop in incidence. Okay. This was over at St. Joe's, and it just shows that over time, that you do continuous quality improvement. While it was very high, the incidence at one time for the actually prevalence facility-acquired pressure ulcers, and then they did a severity index on pressure ulcer, that you could decrease both the prevalence, the facility-acquired incidence, and the severity if you kept at. Every time you got a new report, you take a look who got them, why, and then you kind of tighten down what kind of interventions you do. So the bottom line is that most pressure ulcers can be prevented, requires skin and risk assessment, interventions based on that. I've seen a number of places where they do this, and they've checked that off their list of things that must be charted, and then they don't do anything about it. This does not work. Needs consistent care and critical thinking, constant vigilance and continuous quality improvement, teamwork and commitment. And I just want to say one more thing. You never know what setting you will be in and what you will be responsible for, because a lot of the duties between nursing, OT, and PT can be fluid, even though we have our own scopes of practice, supposedly. But a few years back, I was lecturing in Canada. At the end of my lecture, I found out that the audience was almost all OTs, because in home care, OTs were the ones responsible for pressure ulcer prevention. Who knew? I didn't anyway. But you never know what setting you'll be in and how much you'll have to do this. So anyway, I'm sorry that I went so long.
Would you be willing to come back again next year? I mean, this has already been a year, but I feel like, at least in my own mind, I had a million questions. I'm sure others did as well. There was a new group that's part two of this, maybe, because I feel like we want more. And
Sure.
It just was.
I'd be happy to come back. I'm a big talker, though. You're going to have to give me a longer time. So. Okay, thank you, guys.
Yes. Okay, so I know we gotta get going, but Dr. Lemon, I know you want to say something about that.
Yeah. This is on behalf of our chapter. For you, Maxine, was not paying attention. We want to thank you. You have done a fabulous job. All the exec team did, in fact. And that's why we have a little celebration for them as well, because I know all of you were part of the exec team in particular. But Maxine was behind a lot of things, and you know, being a president of an organization like this takes a lot of behind-the-scenes work, as you'll start to find out. So, thank you, and it's a small token.
Thank you.
Okay, thanks everyone. It's been such a good year, and good luck with the rest of your year.